apart from Harriet, the presenter. Others can mute your mics. Michelle. Mama Harriet, good evening.
Good evening.
So are you ready?
Yes. I am ready to go on. I'm trying to share, but then share my screen, but it's like somebody is already sharing the screen on share so that I'll be able to share my screen. So if Gerald can stop sharing his then.
So is that your screen that I can see?
No.
So what is it? Is it on someone's phone?
Yes. So I think it's Gerald. Mentioning the name.
Who?
Gerald.
Is another person. Gerald.
Yes.
Excuse me, all people on the platform can mute the video and mics so that Harriet can share the presentation.
I think we can wait at least 3 minutes because we are working on the technical issues. So
okay.
We can wait at least 3 minutes.
Okay. Adrien?
Yes, please.
Is everything okay?
Not yet finished, but we are working on it. We can wait.
Okay.
Now I think it's resolved. Harriet, you can share your screen.
Okay, thank you. Okay, so I guess everybody can see my screen now.
Yes.
Yes.
Okay. So, because we are using different internet sources, I would like to switch off my video. I kept it on for a little while so that at least people will see the person who is talking. I think I've been on for a while now, so I'm going to switch off my video so that it will not interfere with others. Okay, so thank you so much, Esther, and thank you, Nutrition Society of Rwanda, for the opportunity to facilitate this CPD so that together we discuss nutrition care process and how to get it right. And I hope by the time we finish, we'll be able to do it and do it well and learn from each other. So, as Esther said, my name is Harriet Jimfua Eduamwa, but you can call me Harriet because I know the rest will be a little bit difficult. I'm a licensed dietitian from Ghana. I am registered with the Ghana Academy of Nutrition and Dietetics, and I'm a member of the African Clinical Nutrition Consortium. You can follow us on LinkedIn. You can just type African Clinical Nutrition Consortium and follow us on LinkedIn on some of the things that we do. That also because there are resources to help with clinicians working in the hospital. I also teach at University of Rwanda at the Human Nutrition and Dietetics Department. So today, as we said, we want to talk about nutrition care process, a very important topic in our area of work. I've worked in the field of clinic for about 11 years, and then it is very important for us to understand this aspect of our work because it shows professionalism and also put us in a level where people understand what we are doing, people understand the language we are speaking, and it becomes a standard for all. Okay, so then in this my presentation, I'm going to give a little bit overview about nutrition care process, a little bit history of it, and then we'll look at why the nutrition care process, why is it important for us to use it, especially in clinic. But I should say that nutrition care process can also be used in community. So then no matter the chain where we find ourselves, whether clinic, community, whether even in full service management in the hospital, we can still use nutrition care process. So then we can use it everywhere in the step of nutrition and dietetics work. And then we are going to look at the steps that are in nutrition care process and then how to integrate it in our system because most hospitals now are using hospital information system. So how can you integrate it in terms of using the ADIME to be able to do that. And I like being very interactive, okay? I like being very interactive. So then there are practical case studies in it, and there are interactive ones that we will try and do here. So I will appreciate it if we can all participate and participate very well to make the whole discussion lively. All right. And I'm hoping that by the time we finish this webinar, we will gain some understanding of the historical perspective and the rationale why we use nutrition care process and the terminology that comes with it. And then we describe the 4 steps in detail, because since its inception, there have always been addition. In fact, there has been addition with the ones that we commonly know. But I'm going to really hinge on the one that is a little bit common, but I'm going to mention the new additions as well, so that when you see it somewhere, it will not be new, okay? And then, as I said, how to incorporate it in our daily care in the hospitals that use hospital information systems. So some of the terms that I'm going to use most of the time is nutrition care process, of course. ADIME, that means assessment, diagnosis, intervention, and monitoring and evaluation. Then I'm going to show the ID&T book. That was the first manual for the terms that are used. So then nutrition care process has its own terms. So most of the time you cannot write a diagnosis, especially with your own words. There are some standard words or phrases that is used. So I'm going to show a little bit about that, because that has also evolved. Now the ID&T book is not in the system so much, but it's good to know because you can still use it, although there have been newer versions of that. And then I'll talk a little bit about evidence-based nutrition practice. So just in case you see those words, that will be the key term. All right, so then let's start. Okay, so then nutrition care process, why is it even important? All right, so then we know that in our work as clinical nutritionists and dietitians, we have always done some form of nutrition assessment. We have always done some form of nutrition intervention for the people we see. We have done some form of monitoring and evaluation. And then we have done some form of documentation. But then the problem is that, or was that, because in some areas it has changed, in some areas it's changing, and in some areas it will change in the future. But it has always been that we have not done it in a systematic way or a standard way. What do I mean by a standard way? You can see that everybody do nutrition as a form of nutrition assessment in his or her own area of work. But the way somebody is writing nutrition problem may be different. We are all talking about nutrition status of the person, but we are saying it differently. The doctors that are... Hello? Yeah, hello, can you hear me?
Yes, we are getting you, but the slide are not moving. I don't know, and now it is working. I don't know what happened.
All right, so it looks like when I put it on slideshow, it does not move, right? But now you can see.
Yes.
Okay. So I think I will leave it like this, because when I put it on, probably when I put it on presentation mode, it does not move. So I will leave it this way. Okay, thank you so much. All right, so as I was saying, we have all used different languages to say the same thing. It makes it very, very difficult for people to understand what we are doing. And it looks like we are always working under people, because historically, dietitians used to work under doctors. But then it means that when you see a patient, how are you going to bill it? Because then the language that you are using, if it's insurance that is paying, you are not really writing any diagnosis. You just write an assessment. The assessment, you are using your own language to even write it. So the insurance company that do not recognize that language, so then they don't know the service that you have. Okay, so then it came to a point where we wanted to have our own language, how we speak in terms of the work we do, in terms of the medical nutrition therapy that we give. We wanted to show the signs and symptoms for which we are treating nutritionally. Okay, so then a group of people from the then American Dietetics Association, which is now Academy of Nutrition and Dietetics, around 2002, decided that let's sit down and have a scientific and evidence-based way of intervening or assessing our patients. Let us sit down to have a language, a standard language that we speak, so that there's clarity and consistency, so that when a nutritionist writes notes, when the person is not there, the other person who will come understands clearly what the person wanted to say. Because if you are using your own language, it will be difficult for the person to understand what really you wanted to say. But if there's a standard language, there's a standard process of doing things, then everybody understands. There's consistency in it. And because we are using a standard language, we are able to pick data to improve the outcome. We are able to improve the work we are doing. We are able to follow up our patients very well to improve their outcomes. Okay, so because if we know that, okay, this is the problem, nutrition problem, and this is what we are working towards, it becomes easier to have a good outcome. And also, it is professionally recognized. As I said, every professional have a standard way of doing things, a standard language that is being used. The doctors have their standard language and then the steps they use. There's ICD, there's CPT codes. The nurses have their own codes, physiotherapists and all that. So there was a need for us to also get our own. So that's how then in somewhere 2003, Nutrition Care Process, the first edition of Nutrition Care Process was published. Okay, so when it was published, what did it encompass, or what was in that? So the Nutrition Care Process was defined as a systematic problem-solving method that food and nutrition professionals can use to critically think, because we already think critically when we are working, but this time we wanted it to be in a systematic way so that we can make decisions that address practice-related problems, specific practice-related problems. So then that is how Nutrition Care Process was defined, all right? And then the standard was intended to be used in our work to guide us in what we are doing. It means that we know what we are doing, but there should be a process that we go through. So it is a standard process, not a standard of care. There's a difference, because if it's a standard of care, it means that we are saying that when everybody comes, treat the person this way. That is not what Nutrition Care Process is about. It is a standard process. So it means that if everybody comes, take the person through this process of assessment, of diagnosing, of putting down interventions for the person, and then following the person up so that it will improve the quality of medical nutrition therapy that you are giving to the person. And then, as I said, Nutrition Care Process is not just for patients, but it's also for groups, communities. So whether you are in community nutrition, community dietetics, you can still use Nutrition Care Process to work and work well. All right. And nutrition care process did not just come just like that. It came with a model. There's a model that helped them to develop the steps or the processes that are involved. So when you look at this picture, you can see that there's an inner core. Okay, my arrow is pointing to it. There's an inner core, and then there are two outer cores that you can see, or two outer rings, and all of them is affecting the steps that we are supposed to use in nutrition care process. So then when you look at the middle core, it talks about relationship between patient, client, group, and even dietetic professionals ourselves. In that, this process is supposed to help us or guide us to have a relationship, a working relationship with our clients. So you ask yourself, does my client trust me enough to be able to open up and give information that I need when I'm doing nutrition assessment? Because we use a lot of information to be able to help our patients, but the patient trusts you enough to give that information. Does the patient see you empathetic enough to give that information? So then the way you behave, the way you look at the patient, the way you greet the patient when the patient comes, all affect that. There should be a relationship where the person can trust you, or the patient can trust you enough to be able to give you that information. And when you look at the outer ring too, nutrition care process do not just look at the individual, but also look at the systems the individual is coming from, or the patient is coming from. We look at the economics of the patient. So then you have to have an idea whether the person is on insurance, if the person is a out of pocket paying kind of patient, how much am I charging my patients and how much they can afford. It all affects the treatment you are given. So if somebody comes to you and then your initial consultation is very expensive and the person do not come for follow-up, it means that you will not be able to go through the process of nutrition care, which is supposed to give quality care. So then you consider that when you are pricing your services. And then the practice settings that you are in, how will you put this in a simpler way for people to understand what you are doing? The social systems that affects your patients, it's a part we also look at to be able to help us put in interventions that will work and work well for our patients so that we will get a better outcome. The healthcare system that we are working in, because every healthcare system have policies and procedures that they use to work. So then that one is also considered. For example, if your facility have certain enteral or parental fees, that is what you are going to work with. You can't work with any other type which is outside. So whatever processes you are putting together should reflect the system and then the policies that is there. And then you can see that the second ring is actually about you, the professional. What is your dietetic knowledge? Would the patient trust you with the information that you are given? That the information that you are given, does it work? That is why we are saying that we use evidence-based when it comes to nutrition care process. Does it work? Will it work for the patient? Has it worked before? Your skills and your competence matters a lot. When you are seeing a patient, your ability to critically think about a problem and come out with intervention, how you collaborate with other health professionals to give the patient a patient-centered care. That means everything that you are doing is centered on that patient, not a group of people, unless it's maybe a community intervention that you are given. And then the code of ethics of the profession. How do you receive patients? You yourself, how do you look? All that comes in with nutrition care process and the communication skills that you have. But and also there are also supportive kind of system. They are not really affecting nutrition care process, but it is needed for nutrition care process to be used and used well in the modern. You can see the screening and referral. We don't do a lot of screenings. We don't do it a lot because most of patients will come and see you. Probably they have been screened already, unless they are the walk-in people that you are doing your screen assessment together. But most of the time, the risks of poor nutritional status may have been identified by another professional, and then the patient is referred to you. So that system also comes in. How do we relate with people who give us those referrals? And also, when you look at this supportive factor is outcome measurement system. So then systems that help us monitor the data that we are collecting. So if for those of us who work in hospitals that have hospital information systems, if you are able to put in nutritional care process very well, then at the end of the quarter, at the end of the month, we can actually analyze how many patients we're seeing, how many were having issues with nutritional status, how many were we able to put it in intervention, came out with better outcome, how many people came in, let's say, the month of May, how many came for their reviews in the month of June, for instance. So all those systems help you to get feedback that can help you better the processes that you are using. So that's how the model of the nutrition care process is done. All right. So then, as we said, the nutrition care process is designed to improve the consistency. So it means that whether you are practicing in the southern province, northern province, whether you are in Kigali, whether you are at the western province, there is consistency in our work. If I move from Kigali to Western Province and I take the nose of a patient, I should be able to understand the nutritional problems the patient had, the interventions the clinician or the clinical nutritionist did for the person, and then the outcomes and what I'm supposed to monitor. Okay, and then it also easily provide the information on how much and what nutrients to give to the patient, because we have standardized it by going through the process. Then you'll be able to know exactly what is wrong with the patient specifically to put in specific interventions. And I said it is also an avenue for us to monitor key variables, because there are signs and symptoms. Those are the ones that we are monitoring, and we are speaking the same language. So everybody who takes it understand what we are doing. Even other health professionals will understand if we write a standard form of language. Okay, so that is why we say nutrition care process and technology, because then they did the standard for the process and then the standard language. We will go through all of them for you to see. Please, if I'm going too fast, please alert me, okay? If I'm going too fast, you can alert me and then to slow down a little bit. All right, let's move on. And I want to reiterate the purpose again, that we wanted a common language for documentation and communication among ourselves and other health professionals. Also, we also wanted to influence the factors that contribute to imbalances, because if we are not speaking the same language, if we are not writing our notes in such a way that we are specific with the nutritional problem, the cause of it, and the signs and symptoms that we are looking at, then it is very difficult to improve the nutritional health of the person. So then when somebody come and see me and I just say malnutrition, I've not said anything. Is a malnutrition because of intake? Is it because it's a clinical condition causing it? Is it because the person did not have any knowledge on what to do to have a good nutritional status? Okay, but nutrition care process help us to be specific. so that every imbalance can be improved. It also is an avenue to also give a very high quality nutritional care. And then the most important purpose, because we have standardized it for our use, okay, it makes us the sole provider of medical nutrition therapy. It makes us the sole provider. So it means that a doctor cannot provide medical nutrition therapy, a nurse cannot provide medical nutrition therapy, and any other outside person cannot provide medical nutrition therapy. It is our sole professional property, okay, to use nutritional care process to provide the nutrition care that is needed. As I said, there are terminologies to nutrition care. So there are always manuals. There are always manuals that is used, okay? And I'm showing some of the manuals that has been available. I think the first edition came in 2005. That is that was the first edition. And after that, there has been a lot of additions with the terms. Now we have the ENCPT, that is the Electronic Nutrition Care Process Technology. That one, I think you have to buy it and subscribe it. But if you have even the old version, you are good to go. The most important one is you having a manual that helps you write the diagnosis better. That helps you to know the standard language that is being used to be able to help. We will go through some of them, but it will be good as a professional to have it. Some of them you can find on the net. It will be an old version. The old versions do not have the additions that are very recent after 2020, but then it is okay. For me, it is okay. At least you have something that is guiding you. But if you have any of these manuals, you'll be able to use it to be able to write the standard language better. So that is it for the history and perspective or rationale behind nutrition care process. Let us zoom in the various steps of nutrition care process. Okay, let us zoom in. So because we say it is a process, it's always cyclic. It is always cyclic. When you finish one cycle, it doesn't mean that you are finished. It is going to start again. What do I mean by that? So then the first step is nutrition assessment. There are 4 steps in the process. The first step is nutrition assessment. Then after you have done assessment, you diagnose. After you diagnose, you do nutrition intervention, and then you do nutrition monitoring and evaluation. And after doing nutrition intervention, you give time for the patient to go and do whatever you are, or client to go and do whatever you intervene. The person counts for the monitoring. Whether the person did well or not, it depends on what happened. We go back to the assessments. So kind of it's always a cyclic one. Till then we are able to solve the nutritional problem for the person, then we can discharge the patient. So let's go through the steps one by one. So the first one is the nutrition assessment. How do we define it? What is it? Okay, so we are saying that is the first step, okay, and it's just a systematic way of obtaining data, verifying the data, then interpreting the data. So in the first step, you are doing 3 main things. You are obtaining the data, the nutritional indicators that you need to be able to know whether there is a problem or not. So all this data is to tell us whether the nutritional status of the person is good, poor, or not so good. So then we are not just obtaining it, we are verifying it. In verifying, we are trying to say that, okay, indicators for somebody who is a female is different from somebody who is a male, is different from a child, is different from a lot of things go into it. So then you have to use that. There's a system to use to verify, then you interpret. Okay, so your ability to obtain, verify, and interpret the data so that you'll be able to use it to know the actual nutrition problem the person is having. Okay, so then usually with nutrition assessment, that's the first step. There are so many ways you can get it because as I said, nutrition care process can be used in all the chain or ripple wings of clinical nutrition and dietetics. So then, whether you are doing patient interview or the patient is unconscious, you can find data in the records, medical records. Sometimes the referring person will give you some information. Sometimes you can get information from family if the person cannot give you any information. So there are so many ways to get information if the person is an individual. And then if we are talking about groups or community setting, you can get data from survey that has been published to be able to know the nutritional status of the group you are working with. It can be surveys that you are doing yourself. You can pick it from statistical reports, epidemiological studies, and all that. So there are so many ways to get your data depending on the patient or client or the community members that you are working with. Then when it comes to nutritional assessment, there are domains. So usually the processes are there, the steps are there. Under the steps, we have domains. Okay, under the steps, we have domains. Traditionally, there have been 5 domains under nutrition assessment, but recently 4 more domains have been added. But do not worry about that one because if you look at the other 4 domains, we usually add it to our work. And the other 4 domains, the reason why they are there is because of reassessment. Because when a patient comes and you assess, after monitoring and evaluation, I said that you have to reassess. So in the reassessing, there are some information that you use. So then that's when you use some of the domains, and then I'll clarify that one when we get there. I'm so sorry, it is raining in my area. So then in case you are hearing background noise, it is the rain, but I'll try and speak louder so that everybody can hear me. All right. So let's take the domains one after the other. Okay. Let's take the domains one after the other. So the first domain that we want to look at under nutrition assessment is anthropometric assessment. Most of the time you will see AD. Okay, if you have some of the manuals or you are using the terminology software or book, you will find these is it acronyms? Yeah, with it. Okay, and that anthropometry are just saying height, length, weight, body mass index. Now, because BMI is not so conclusive for us as clinicians, we are looking at further to percentage body fat, percentage body mass, visual fat, waist circumference, waist hip ratio. Now we have the waist height ratio. We have the BMR that tells us the energy requirements that we can give the person. Okay, some machines can calculate for you. Then we have skin fold measurements, MOWAC, growth rate, and then rate of weight change. They all fall under the anthropometric subclass of anthropometric domain. Then there's a food and nutrition related history. Usually if you see FH, it's telling you that whatever data is there is from food and nutrition related history, which includes the diet history, 24-hour record, the food frequency, usual intakes, and all that. It also take information. You also take information on supplement use, nutrition awareness, and other things the person is doing that is concerning the person's nutrition, the attitudes and beliefs that a person have concerning food, physical activity, whether the person have food access or not, or availability of food. They all go under that one too. Then we also look at biochemical data. Biochemical data, medical tests and procedures. Because we are seeing patients from OPD to IPD, we are seeing patients who are critically ill. We look at the whole spectrum. So then the labs like lipid profile, glucose, we look at CRPs, electrolytes, kidney function test, renal function test, liver function test. When it comes to the feeding, we can look at gastric emptying, motility in the GI. We look at all that because they all inform us whether the person has some nutritional problem or not. So what the domains do when it comes to nutritional assessment is that it's kind of one domain kind of help you verify another domain. So anthropometry, when you have anthropometry, then some biochemical data help you to even verify it. If somebody, let's say, have poor nutritional status, albumin can help you verify it and say, yes, it's true that what I'm seeing is actually what is there. So most of the time, they tend to be validating markers or indicators for us. And as I said, dietary assessment methods, there are a lot of dietary assessment methods that you can use depending on the individual, the age bracket. We know that for 24-hour record, we can't do 24-hour record for an aged person or a child. Okay, so for an aged person or a child, we do food frequency questionnaire. Okay, sometimes people with diabetes and other eating problems, it's better that you do food diaries or food records for them. And that is when you actually give them something or a booklet to go and write everything they eat, document it for you so that the next review you will see. So then depending on your patients, depending on the kind of condition that you are seeing, you choose the right tool to be used for that person. So it's very, very important that you understand which tool I'm using and for which particular population or person I'm using it for. Then, as I said, we need the labs too. We have to know the labs that are nutritionally related. It is not all the labs that are nutritionally related. It's like somebody going to do malaria tests. You don't need malaria tests to look at the nutritional status or to look at an organ failure or organ dysfunction. Okay, so then you have to consider the labs that are nutritionally related, and then you ask for them or you write for them depending on your healthcare system, whether they allow you to write labs or you have to work with a doctor to be able to write for you. But at least you have to know the lab you want so that if somebody have to even write on your behalf, you tell the person what you want and why you want it. Most of the time, at places where the system do not allow the clinical nutritionist or dietitian to write labs, most healthcare services or institutions allow that, but some do not. The ones that do not, you should be able to explain to the person that you are working or the doctor that you want to write for you why you need it, so that it will be like a team work. And then we have the nutrition focused physical examination. Nutrition focused physical examination. That is also a verification for us. Somebody have malnutrition. Okay, so if you do the nutrition focused physical findings, it verifies for you whether it's muscle wasting, whether it's subcutaneous fat, whether there is I'm saying that the person is having anemia. What are some of the signs that I'm seeing to say that the person is having anemia? And we do the physical examination to find some of those findings or signs and symptoms that we are looking for. Okay, so I always tell people that as a clinician, you have to touch your patients. You have to do some form of examination, especially with initial consultations. Initial consultations, you have to do some form of nutrition-focused physical examination to be able to know the specific nutritional problem that you are working with. So you can't do one domain and leave the rest. Most of the time for initial consultation, you have to do everything. So that's why initial consultations usually takes longer. Initial consultation can take between 45 minutes to an hour to finish because of all these assessments that you are doing. And then it's also part of the nutrition assessment domain for you to do or for you to take history, clinical history. And in the clinical history, you are just looking at for past medical, social history. Okay, so then you want to know if the person have any medical condition apart from the one that the person has been referred with. If the person have any family history that you believe that if is not considered can create other nutritional problems. Somebody with obesity coming to see you. We know that obesity is a risk factor for a lot of non-communicable diseases. And we know that having a family history also increases that risk. So you have to ask that question, whether the person has a family history of any of the non-communicable disease, so that in your intervention, you are also considering the fact that the person can have risk of hypertension, diabetes, or high cholesterol. So you factor all that in your intervention. Okay, if there has been any surgical history, medication history, very important. What medication is the person taking? Somebody can come and see you because the person is diabetic, but you need to know what medication the person is on. Is the person on insulin? Is the person on oral hypoglycemic medication? And which type of oral hypoglycemic medication is the person on? Because we know some of them can lead to hypo. And you have to inform the patient when you are counseling or educating. So it's very important for you to know whether the person is on medication, what medication the person on, how many times the person is taking it. Especially those who are on insulin. We know that people who are on long-acting insulin will need snacks in between their meals. So if you don't know, if you don't ask medication history, and then you just do a meal plan for the person can go into hypo because you didn't consider the times that the insulin is going to peak, and you need to put a snack in there for the person. Okay, sometimes some people are taking some herbal medication that have nutrient drug interactions with some of the things that you are giving. So if you know, you'll be able to educate or counsel the person concerning that. And then social history, very important. Social history of the person, because then the intervention you are giving, can the person afford it? So usually we say that you intervene with the person's preference, or if the person can afford it, that is good. But then you have to know that whatever you are doing for the person can afford it. Is it culturally acceptable by the person? A lot of people have cultural identity or ethnic identity, or even religious identity. So then if somebody, for example, if somebody who is a 7-day Adventist is your patient, the person need omega-3 fatty acids. You can't force the person to eat mackerel because we know that they don't eat fish without scales. So then if you overlook this information, whatever intervention you put in, the person cannot do it because you didn't consider the religious identity, which is very important for your nutrition intervention to go well. The educational level of the person, very important, so that you know how to communicate the intervention to the person. You don't use large or in-depth medical jargons when you know that the person have a primary education. You have to put the intervention, education or counseling, you have to put the language to the level where a primary school liver can understand. The living situation, is a person married, is a person living alone. It all affects the intervention that you are doing. Can the person go for shopping? Do you need to do shopping lists for the person? In other areas of the world, dietitians, there are some dietitians that do not even work in clinic. Okay, their job is to help people do the shopping list. So when you come, they look at your condition, they look at the diagnosis, and they are able to help you do the shopping list. All right. So then all these things are considered when you are doing your nutrition assessment. All this history, you cannot overlook it. Okay. You cannot overlook it. You have to take all this history. And as I said, the 5 domains that I've just spoken about, they are the traditional domains from the start. But recently, Academy of Nutrition and Dietetics, in aid with the International Confederation of Dietitians, have added some domains. Okay, have added some domains. And as I said, some of these domains are used when we are reassessing. You are not supposed to use it when you are actually assessing for the first time. It is when you are assessing. So the 4 domains they have added is the comparative standards. They just added that for which probably you can use to calculate the caloric need of the person in a day. Because if you have taken a diet history, you want to know whether the person is eating what the person is supposed to eat. So then if you have calculated maybe the person's daily intake, and the estimated energy requirement for that day is 1,005, but then you realize that the diet history that you have taken, the foods the person is eating, when you calculate the energy in it, it's giving you about 1,000 calories, or it's giving you about 2,000 calories. So you know that whether the person is taking excessive of it or taking inadequate energy. Okay. And then they have the assessment, monitoring, and evaluation too. That is when you are doing the assessment. A etiological category helps you to be able to actually assess the cause of the nutritional problem. Then progress evaluation is usually related to the goal that you had, and determine whether or not the nutrition diagnosis has been improved. So that one, usually you look at it in reassessment. So the ones that you have to really worry yourself or do not forget when you are assessing patients is the 5 domains that we discussed earlier. Okay, but at least when you see the 4 elsewhere, you know that it is now added to the domains of nutrition assessment. Okay, so as I said, when you have taken all your assessment indicators, there are questions that you ask yourself. Have I obtained the right information, verifying them? It is always good that when you have obtained the indicators you need, you cluster them. Okay, so that is why ADEM or incorporating it in your software, or even if you don't have the software and you have assessment sheet, that's the main reason why you have to have your own assessment sheet, design your own assessment sheet where you can cluster them. Okay, so that when a patient comes, you don't start with nutrition assessment and then you don't know what to do again, you do weight and all that. But if you have already clustered them in your system, then you know that when the patient comes, I'm doing anthropometry. When I finish anthropometry, so the things are there. So you look at it and feel it. It makes it very easy for you. Okay, so when you cluster them and organize them, it helps you to be able to sit down and then find the nutrition problem easy. Then you evaluate the data using reliable standards, whether it is a laboratory data or a anthropometric measurements. There are standards that you can compare it to know whether your patient has a problem or not. So then you'll be able to do that. So then what are some of the critical thinking you are supposed to do when you are doing nutrition assessment? What are some of the critical thinking? Remember, I said that our work is 80% critical thinking. We do a lot with people, and the fact that we want them to tell us the truth so that we can have a better history to help them. So you always observe verbal and non-verbal cues. Okay, when you are interviewing a patient or you are picking the assessment, always observe. Is the person withholding information? The non-verbal cues, always observe so that you'll be able to know how to help the patient to relax and give you the information. Some people become a little bit uncomfortable when they are supposed to talk about what is happening in their house. You are asking them their social history. Some of them become uncomfortable, but it is your duty to tell them or inform them that I'm asking you your social history so that I'll be able to, in a holistic way, help you in the nutrition problem that you brought. So then you determine the appropriate data to collect. Very important. We have all these indicators that we are collecting, but then what is the appropriate one for the condition in front of me? Somebody comes with celiac disease. Now that you want to go and take waist and hip circumference, the person really is coming with a GI issue. You have taken into weight and height, BMI is normal. Go to the next slide. So determine the appropriate data to collect. Or even if you collect everything, determine your ability to determine which one you are going to use for this particular condition is very, very important. Okay. Then your ability to select the tools. And procedures, okay, and applying it in a valid and reliable ways. What are the tools that are there for anthropometry? There's dynanometer. What is dynanometer used for? If I want to check the strength or the frailness of a patient, I can use the dynanometer. So it means that if my patient did not come with any condition that I have to check frailty, I don't need to use the dynanometer because we are working with time too. So your ability to select the assessment tools and procedures and apply them in a valid and reliable way, it is also very important. Then distinguishing relevant from irrelevant data. While the patient is talking to you, your ability to distinguish that this is relevant for my work, this is not relevant, so that the patient will not waste your time, number one, so that you will not pick information that you don't need, okay? So then you have to critically think through it. When we are starting, it's a little bit difficult, but the more you do it, the more you become conversant about it. Then organizing the data to relate to the nutrition problems. You organize your data in such a way that you have a bigger or a blueprint of data that can help you to know the nutrition problem or problems the person is having. Because some of our patients comes with an array of conditions. The person is diabetic, the person is have obesity, the person is hypertensive, the person is having some chronic kidney disease. So then your ability to organize them, the data that you have, to be able to relate to the nutrition problems that the person have. Remember, we don't treat medical conditions, we treat nutrition conditions. There's a difference. When we are talking about the next step, we'll talk about that. Okay, and then you always have to know when you are required to refer. Okay, please don't try or don't force to do what you are not supposed to do, especially clinicians that are working in areas where it is very difficult for the person to accept the diagnosis the person is coming with. don't try to overlook it, because the person will not do the intervention. The person is feeling that I don't even have this condition. I think you see how in my years of clinic, I've heard a lot of stories. Somebody is diabetic. The person is saying that is somebody somewhere that is doing that. I just refer to a psychologist. Somebody have an eating disorder. I like to refer to a psychologist for the person to start his or her work, to cancel the person. Then I can continue what I am doing. Very important, depending on the condition that you are seeing. Okay, and then the next step, please, is there any question on the first step of nutrition care process? That is the nutrition assessment. Is there any question before we go to the second one? I think that will help us. Or there's a question in the box, I'm not so sure. Please, is there any question?
Anyone with a question can unmute the mic and ask a question before Harriet continue to the next step. No question?
Okay, so
Harriet, let's proceed.
Okay, sure. Thank you. But please, if you have any questions, you can put it in the chat box so that we can refer to it easily. Okay. All right. So let's go to the next step. So now we have taken our nutrition assessment indicators. We have taken our anthropometry, our food and nutrition related history. We have done our clinical history. We have done our nutrition focused physical findings. We have done the biochemical, if it is available. We have seen it. We have recorded it. We have verified and evaluated our assessment information, critically thought about it. Everything is fine. The next step is to diagnose. Okay? The next step is to diagnose. So the next step you are going to do is to look at how we diagnose nutritionally, not medically. Diagnose nutritionally. Okay, so then the definition of nutrition diagnosis is just identifying and labeling a nutrition problem that the dietitian or clinical nutritionist treats independently. Okay, we are saying that treat independently because you are treating yourself. You are not treating with the doctor. Okay, you are not treating with the doctor. It is a problem you are supposed to put interventions to treat a nutrition problem. All right. And then they also have standard terms that is used. Okay. We use standard terms to diagnose. As I said, especially in diagnosis, we don't usually use the whole statement. It's not, we don't use our own mind, if I should say, to write the statements. There are some standards or some terms that we need to use, and that's what we want to look at now. That is what we want to look at now. I have a very, 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 very old version of the manual. I'm sending it to Adrian, and Adrian, if you can put it so that people at least can have it for now, because I know it may be difficult for some of us to, or if somebody has a newer version, why not you share it with us so that we can all use it. Okay, I'm trying to share whilst I'm also talking, so I believe that eventually you get it. All right, so then with nutritional diagnosis, we are saying that we identify a specific nutrition problem that the dietetic or clinical nutrition practitioners can treat. A specific. We always want to be specific, not so broad. Not so broad that we don't know which one we are treating. A specific nutrition problem, okay? The problem may already be existing, or the person may be at risk of getting it. So then it can be that the person came with diabetes. So then the nutrition problem is already existing. That's why the person got diabetes. Or it can be that the person is going for surgery. If the person is going for surgery, we anticipate that because of the surgery, the person may have some nutritional problems. Okay, so that is when we say that we can also write diagnosis for what we anticipate. We anticipate that the person may have. Okay, and then there's a big difference between medical diagnosis and nutritional diagnosis. Okay, medical diagnosis and nutritional diagnosis. So medical diagnosis is usually done by doctors. Okay, medical diagnosis is usually by doctors. It is showing a dysfunction of an organ. Nutritional diagnosis is specifically to a nutritional problem. So it can be excessive nutritional problem or inadequate nutritional problem. It can be a clinical form of nutritional problem. It's specific. So then it means that nutrition diagnosis is something that nutrition can solve. Okay? Nutrition diagnosis is a diagnosis that nutrition can solve. So then that is the difference. So then the diagnosing that we do is quite different from the diagnosing that the doctors do. Ours is supposed to be treated with nutrition. So then food becomes our medicine. Food becomes the medicine that we are using to treat these kind of conditions or problems that we have. And then traditionally, nutritional diagnosis have had 3 domains. Okay, nutritional diagnosis have had 3 domains traditionally, but recently they added 1 domain to it. But I believe that the 3 domain is still strong and standing. So then you just need to know about the 3 domains. The other domain is the nutritional situation. It is just when you have additional information that can also be used to write a new diagnosis for the person. But then the one that you have to really know and use are the 3 domains that we are going to discuss. So if you are going to diagnose, you diagnose under one of these 3 domains. You don't diagnose from all the 3 domains. You have to select the diagnosis under one domain. Okay, under one domain. So then let's look at what is in the intake domain. As I said, we have intake domain, we have clinical domain, and then we have the behavioral and environmental domain. And under each domain, there are classes. Okay, so we will look at that. That is why I said we don't write the diagnosis from our mind. Don't try and memorize these ones. Just work with it, and over again, it sticks into your mind. So then when it comes to the intake domain, we are saying that the intake domain is defined as a problem related to intake. It is related to intake. So whatever problem you are finding, you realize that the person is either taking excessive or inadequacy of a particular nutrient. That is what is causing the problem. So that is why it's an intake domain. So then there are subclasses. The subclasses will tell us what exactly is the person taking excessive or inadequate. So then that is the label that we usually use. Excessive intake of this or inadequate intake of that. Okay, so then we have 5 classes under the intake domain. The first class is calorie or energy. So it can be excessive energy intake or an inadequate energy intake. Or it can be nutritional support. So because we do enteral, parenteral feeding, or even oral nutrition supplements, it can be inadequate oral nutrition supplements, or it can be inadequate enteral feed, or it can be excessive parenteral intake. Okay. And then it can be fluid. The nutrition problem can be fluid. Okay, so it can be excessive fluid intake or inadequate fluid intake, depending on the assessment. So the assessment you do help you to know the problem you are dealing with nutritionally. It can be intake of bioactive substances, bioactive substance like alcohol. Okay, so there are some people who take in excessive alcohol that can hinder or that can have effect on their nutritional status. Okay, so then from your assessment again, you find out whether the person is eating because of excessive, the person is not eating because of excessive alcohol intake. Okay, but most of the time we confuse that one. Then we say that it's a inadequate intake of energy and protein. But most of the time, after looking the assessment again, you realize that it is the excessiveness of the alcohol intake that is hindering the person to eat actual food. Or it can be nutrient imbalance. Okay, so it can be that the person is not taking excessive vitamin D, excessive vitamin A. You can be specific. So under the classes, you can be specific. So if it's a particular nutrient, it can be only protein that is like the nutritional problem is the protein. So it can be inadequate protein or inadequate intake of vitamin C or something, for example. All right. So then the first domain, we know that when we do the assessment, we find out whether it's an intake problem. If there's an intake problem, what exactly is the person not taking? Is it calories? Is it oral nutrition support or enteral or parenteral nutrition support? Is it fluid? Okay, in terms of hydration, is it bioactive substances, or is it some nutrients that are not balanced in the person? And then the next domain is clinical. So there are some people, the nutritional problem is not really about intake, okay, but about a clinical condition that is going on that has caused the nutritional status to be poor. Okay, and that one has 3 classes under it. It can be functional. Functional means that there is something about the GI. There's something wrong with the GI. So it can be chewing. So the person's nutritional status is poor because, not because he cannot take the food, but because he cannot chew. Okay. Remember I said that the nutrition problem in the diagnosis should be specific. Okay. So you can't say that functional imbalance. No. You have to be specific that the person have chewing problem, swallowing problem, absorption, digestion. Okay, they are all functional because somebody can be underweight, not because he's not eating or not because the food is not there for him to put in his or her mouth, but because probably he cannot chew, he cannot swallow, even when he eats the food. From the diet history, you realize that he's eating the right amount of protein or the right amount of vitamin B12, but because probably there is some absorption problem, that's why he's being deficient in that micronutrient. So that becomes a clinical problem, not an intake problem. Okay, there are sometimes too there are biochemical imbalances. Okay, there are biochemical imbalances, so that you will know that okay, this one, it is the altered labs. Especially in diabetics, you can find somebody with HbA1c that has been altered, okay? That is causing the nutritional status to be poor. So then you choose the right one. So then the document I've sent, you can see that they have classified all the statements or terms you can use under these domains. So it's easier for you. All that you need to know, whether it's an intake problem or clinical problem, when you go into the document, it will show you, okay? It will show you the things under that. And then you can see that most of the time you can see that one of your problem is falling under that. Okay. Then the next class, the weight balance. The weight balance. There are some people who are putting on weight not because they are doing excessive intake of calories. It may be some medication that they are taking. Asthmatic patients, or somebody is on contraceptives, or somebody is on how do they call it, psychological medications, those with mental health issues. Some medication for depression can cause weight gain. So then after your assessment, that's why you see we are even asking about medication under the assessment, so that we'll be able to know specifically what is causing the nutrition problem. Then we have the behavioral. We have the behavioral and environmental. So some people, their nutrition problem is because of their lack of knowledge. Okay, nutritional knowledge deficit. It may be because of the attitudes and belief. It's not that the food is not there. It's not like they cannot take it, but then because of some attitude towards food, some selective attitude towards food, not because of any cultural or religious attribute. The person has just heard on the radio or something, which is not evidence-based. So then you try and educate the person, or the person is inactive, okay, or there is no access of food. So then when it comes to behavior and environmental, they have three classes: the knowledge deficit, the physical activity and its function, and then the food safety and access. And as I said, there's a new addition, which is the nutrition situation domain, which is usually related to the findings, provide like the additional context the person give you, and you want to have another diagnosis. So this is how we write diagnosis using PES statements. So after we have known that the problem, okay, is intake, clinical, environmental, or behavior, we then know that, okay, this is an intake problem, okay? So that will be the problem that is represented by the P. So that is the nutrition problem. That's why we say it should be specific. You cannot write, please, as much as possible, try not to write more than one PES statement per patient per time, okay? As much as possible. Try to write only one statement at a time so that it will not confuse you. So then we have the nutrition problem that you have labeled, whether it's intake, clinical, or whether it is behavioral or environmental. And then you come, what is causing it? From your diet history, okay? From the labs, from the anthropometric measurements, from the physical examination that you have done, from all the history that you have taken, what is the root cause of this nutritional problem that you have found? Okay? What is the root cause of it? And then, what is the evidence that you are seeing? What is the evidence about the problem that you are seeing? That is the signs and the symptoms. So then, whatever is happening to the person, the root cause of it, and then the signs and symptoms you are seeing, or the evidence you have to say that it is true that this person have this nutrition problem and is being caused by this. That is what we call the signs and symptoms. So then the statement will, with the PS statement, always have to be the nutrition problem label that you choose related to the root cause, what is causing that problem, evidence by the signs and symptoms, the evidence that you are seeing to say that, yes, this is the problem. And I gave an example, okay, that inadequate fiber intake, that is the nutrition problem label, okay, inadequate fiber intake related to lack of nutrition knowledge about desirable quantities of fiber. Evidence by patients' intake of fiber that is insufficient when compared to the LDA. So you can see that I'm so specific with my nutrition problem. This person probably came with high cholesterol. The person have normal weight, okay? The person's BMI is within the normal range, waist circumference is normal, hip circumference is normal, hip waist ratio is normal. The person is having high cholesterol. You took the diet history and realized that the person has a very low intake of fiber, okay? But also because we actually, you know that with cholesterol, your body can produce. So most of the time we eat more than we should. But if we are taking in some other foods, it helps remove the excess cholesterol. So then for you believe that the problem the person have, because it's not related to obesity, because the person have normal parameters, okay? So then the problem you saw is that there's inadequate intake of fiber. And what is it related to? What is the root cause of this inadequate fiber intake? You realize that the person have no knowledge. The person have no knowledge of it. Per the diet history that you are taking, the person doesn't even think about fiber, okay? About how much fiber and the quantity is supposed to take. Nobody has said anything like that to the person before. What is your evidence? Why are you saying that the person lack knowledge about desirable quantities of fiber? It is because when you did the diet history, you realize that the amount of fiber the person is taking in the food that she's eating is lower than recommended per his or her age at that particular point in time. So you see that you have the nutritional problem, you have the root cause of it, and then there's evidence to prove that it is true that this is the problem. Okay? So it is very important that when you write a PES statement, you go back and evaluate it. All right? You go back and evaluate it. So then we know we have to write PES statements. We know PES statements is nutrition problem, root cause of it, that is a etiology, and then the signs and symptoms that are evident of the etiology. So let us see some of the things we will do to make sure or to know whether we are writing a better PES statement. So, as we said, P, specific nutrition problem, always remember specific. E, the etiology or root cause contributing, or risk factors contributing. So it can be, you can find a direct cause or you can find a risk factor contributing to that. The signs and symptoms, always measurable. Your signs and symptoms should be measurable. It should be measurable. It should be measurable. Okay? Then the evidence you are picking is measurable, and we will understand it why it should be measurable very soon. Okay? And then you summarize everything together. So we are saying that you evaluating, starting to evaluate, or the critical thinking that you have to do when it comes to your PES statement, you ask yourself, is it clear and concise? Is your PES statement clear and concise? Is it specific to this patient? If somebody takes the nutrition assessment, will the person see the same problem I've seen? Okay? Is it limited to a single nutrition problem? Is it accurately related to one etiology? Okay? Is it based on signs and symptoms from the assessment data? The assessment data I have, will I find that signs and symptoms that I've written? Will I find it inside? If you can't find it, go back and write it again. So after looking at all this, if your nutrition problem is not specific, it's not concise, it's not so clear, go back and write another diagnostic statements. And there are some questions you can also ask yourself, okay? As I said, going through the nutrition care process is practice, 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 okay? It is practice, practice, practice. Don't practice alone, practice with a colleague because then it helps. So then there are some questions you ask yourself to evaluate your PES statement. Can you resolve or improve the nutrition diagnosis you have put down? That's the first question. Can you resolve it? Can you put in intervention to resolve it? Okay. When you are very confused, when you are very, very confused about the nutrition problem, tackle intake domain first. When you are confused, look for a problem in the nutrition assessment you have done. Is there any intake? You go through it and say, is there any intake? Is it taking excessive or something or inadequate something? If you are confused, you can use that method to help you. Okay? You ask yourself, will my intervention resolve this root cause, the etiology, the intervention? Will it resolve it? If it can't resolve it, rewrite it again. Then, can your intervention lessen the symptoms? If it cannot resolve it entirely, can it lessen it a little bit? And then,
Harriet?
Yes, please. I just saw your message. That is fine with me if it's fine with you guys.
So, because it's already 7:33, and PPP is still March, and as we all know, tomorrow we still have to go back to work. So I was suggesting to do this in two parts.
Okay.
And I think we will arrange it in a few days to come, and we continue with the two next steps: intervention and monitoring and evaluation.
That is okay.
But at least today, people, if they already were being concentrated on assessment and diagnosis, we can ask questions. You answer them. And then next time we will resume starting from the intervention and monitoring and evaluation.
Okay, that's fine with me. That's fine with me. So can I?
Yes, you can done with diagnosis.
Okay, sure.
Thank you.
All right. So then, as I was saying, you ask yourself this question: are your signs and symptoms specific enough for you to be able to improve or resolve it? So then, if you ask these questions and then your answer is yes, yes, and yes, then you know that your overall PES statement, it is right, or your diagnosis is right for that particular nutrition problem. So then you can state example of PES statements. It can be swallowing difficulty. That is a problem I saw related to stroke, which is a physiological kind of change that is happening. Okay, the etiology as evidenced by coughing following drinking of liquids. Is it specific? Yes. From my nutrition assessment, I realized the person cannot eat because he cannot swallow. What is the root cause? Why is the person afraid that he is not eating? So you see, it's not an intake problem. The person said, I cannot eat. Why is the person not eating? I find out he's not swallowing. So then it's not an intake problem. It's a clinical, it's a functional problem. So then I write that it's swallowing difficulty. Why? He said that since I had stroke, or the caregiver said since the person was diagnosed of stroke, the person is not able to do that. That is the root cause. So you see, my nutrition problem is very specific to these patients. What is the evidence I'm seeing? The evidence is that they told me, or the nutrition assessment is saying that he coughs after drinking water. That means he aspirates. That is why the person that do not want to eat at all because he cannot swallow well. So I know that this my PES statement is a yes, yes, yes. It's specific, it's concise, it is easy to put intervention. I can measure my change because whatever it is, if I put in intervention, the person can come back and say, okay, now I'm able to swallow or not. So it is measurable. Okay? It is measurable. So I think that was the last slide for diagnosis. So I will pause here so that if somebody has a question, the person can ask it. If somebody has a question, the person can ask it.
Thank you very much, Harriet. This was very interesting, and on my side, I've gained much, and I really appreciate the knowledge you're sharing. So the floor is open for everybody with a question. So if you want to ask a question, you can unmute your mic and ask. So Harriet is here for us to answer. Thank you.
Esther,
Yes.
I think even people are allowed to ask the question even in Kinyarwanda so that you can translate for them.
Yes. So nta kibazo umuntu wese ushaka kubaza waba ugowe no kubaza mu cyongereza nta kibazo wabaza mu kinyarwanda Harriet tukamusobanurira nta kibazo hanyuma agasubiza. Ubwo bisobanuye ko twabyumvise cyane cyangwa ntacyo twumvise. So Harriet.
Yes, please.
There is a person asking if we are going to get this presentation at the end.
Yes. I will share the presentation at the end.
Okay.
I have my own question that I can ask.
Okay, Adrie, you're welcome.
So if you consider the nutrition care process according to how it has been presented, I think, and everyone can see that it can take a long time, and you have so many patients to serve. So I'm asking, what are the techniques that I can use so that I can serve so many patients?
Okay. So usually there's standard time depending on the patient that you are using. So then if you already have a system where you have put the nutrition care process in the form of ADIME, so that like your hospital information system have assessment and everything, it's about clicking. You don't need to be writing a lot. That is number one. And then number two, you have to, that's why we encourage you to do booking. If you have OPD patient, do booking so that you know that if it's a new patient, you are not supposed to spend less than an hour with the patient. The assessment takes some time. The initial assessment takes some time. So then the standard time that has been recommended is between 45 to an hour. And then that's another one that you give yourself time, that I'm going to use this time. And if it is possible to put it in your system, then you just be clicking, okay? You don't need to type. And you click, you put in anthropometry, the system is able to calculate BMI for you. Now, it's not now that you're going to calculate BMI. If you don't have that system, the next thing that you can do also, most of the time, what I encourage people to do is to be able to know the condition and the specific information you have to take. You don't need to take all the information. So then if it's diabetes, because you know you don't have time, then you can take anthropometry, diet history, maybe some social history, medication history, and then you use it to start the intervention. When the person comes back for review, then you can take other information that can give you a better and bigger picture. So then you can actually divide like what you are doing for the person. Because at the end of the day, if it's a diabetic and then you take anthropometry and the person's BMI is already on the roof. You take diet history, which are the two most important ones. You take social and some medication history. You can start some intervention for the person. Okay, you can start. Then you see some nutritional problem there that can help you start some intervention. And then when the person come on review, you tackle the others because then it gives you more time to be able to see other patients. So most of the time, that's what I advise people to do.
Are you answered, Adrie?
Yes, I'm answered. But the other question, which is, I think it is very simple, but it is very crucial. For example, we have different kind of populations, and among the suggestions that the presenter was talking about, it's just to consider the social status of our client. And we know in Africa, most of our patients, they don't like to go to look for nutritionists, but for sure they need nutritionists. So I'm asking for her, what are the approach that we can use so that our population will be served, considering their social status, but also considering the real situation of nutrition needs.
Okay, thank you. So then most of the time, we have to do a lot of education. Okay, most of the time when we are waiting, as you said, Africans do not that health-seeking behavior of Africans are very poor. So then we do a lot of education. So that's when it comes in that even in churches, mosques, in communities, we do a lot of education. And then we direct their focus to us, that we are the professionals that are qualified to help you with nutritional problems, because there are some nutritional problems that will not give you any sign and symptom, but it's there. Okay, so then through that we can organize screenings for people, but most of the time what I do personally is having talks in churches, at organizations. There are lots of issues with bankers. There are a lot of research that has been done in bankers. They can afford to pay for the service, but then they believe they don't have time. So sometimes doing those education for them, maybe having slot to talk to them, some of the nutritional challenges that they may have, they don't even know. You realize that most of them get to understand what you are doing and they come to see you. So specific people, there have been a lot of study that has been done in bankers, in people that do a lot of sedentary lifestyles. You can also link with these gym clubs and all that, because people just go there for the exercise, forget that it is nutrition and the exercise going together. So then education in those areas, because if the person can pay for a gym, the person can afford you. Most of them can afford the services of the nutritionist. We going there selling ourselves to them, to catch them, to change their mind, and then we can get people coming in. But for now, if you don't do that, it will be difficult for people to come in just by themselves. Okay, thank you.
Thank you, Harriet. So Joseph has raised the hand, so we can hear from him.
Good evening. Thank you. So I want to ask, I think I would maybe ask this question after the whole presentation. I mean, like the whole, after the NCP, but I just want to hear like what Harriet can advise on us here, just in general, because we can see that we have now, we covered the NCP, but I want to ask her, like, how can we, I mean, in our healthcare system, or like particularly in the nutrition department units, when you look on how we write in our files, it's just like people just write medical diagnosis, then they write down the intervention indices. So it's not really organized so that you can even look into, you see what is the nutrition problem and what intervention the nutritionists have put in place. So which is still now a big problem in our healthcare system, in the hospitals and everywhere. So I want to ask Harriet, like, how can we, what advice can you give to RNS? Like, do we have to have a standardized form where we can start, we can just pull out and organize, and if any hospital that needs it can take it and adjust it depending on the people it's serving, or like these other ways of we can really tackle this problem. Because if now you go in a particular health facility, say Ashika, King Faisal, any district or hospital, I'm sure that finding the problem of most of the problems why the real problem the patients are having in terms of nutrition, so that you can even see, oh, this is our patient, this is the problem they're having. Also, that can trigger doing research and etc. It's still a big problem. So what is Harriet is advising us, like in terms of having a standardized way of delivering our nutrition, medical nutrition therapy or nutrition care? So yeah, over to you. Thank you.
Okay. Thank you, Joseph. I think that in a way you have answered. It will be very good to have a standard form, okay, for the association or for the society, so that we say that, okay, this is a standard way of recording. And then another way is training like we are doing, so that those who don't know, those who knew partially, those who are a little bit confused will then be trained to know what to do. Because most of the time, some of these things, they can be new in a country. So then we may be practicing without knowing the right thing to do. But then the trainings that the leaders of the society has put in for us, if we are able to do those trainings over and over again, you will see that people start changing how they write it, because now there was no knowledge. Okay, there was knowledge deficits, but now since there's knowledge and then we put it in practice, we train, we put it in practice, and then we learn to write it that way. And then if the society comes together to bring a form that is easier for everybody to use, that will also be perfect. So that's what I can say for that question. Yeah.
Thank you so much. Thank you.
Okay. Thank you, Harriet. There is another person who raised the hand, but maybe he canceled it. She canceled it. I don't know. Any other person with a question before we close?
Maybe I don't know if we can hear someone from RNAs regarding the question I asked, like if depending on what is Harriet is Harriet's answer, what they can just tell us today, like how can we improve on that end and what can be done, and so, and also we, as a way of a follow up, and we hear from them what they are thinking, what can be done, or like they'll be answering this question when we are finishing this.
Joseph.
Yes.
Maybe before we hear someone from RNS, I know we have the way we have to write our notes in the progress notes. Maybe people are neglecting it. Other people doesn't know how to do it, but we have a procedure. We have the method, SOAP method. I think SOAP method is used for every healthcare profession, even in the nutrition. We have to write depending on that procedure or that method of SOAP: subjective, objective, assessment, and plan. So I don't know if maybe you're asking something apart from that. Is there any way that maybe you think or you suggest
so
people can write?
To answer your question, that is organizing the notes into like what you are writing. But like in a patient's file, like you see the nurses, they have their nursing care process, and they have a form into the file of the patient. But that file is there. If you go there, you can see their nursing care. And when you're writing in your progress note, also you can use SOAP as you're mentioning. But we also need that file if we want and to be filed into there. Like that's what I was trying to bring us today and hear what we can do on that end. So I don't know.
If maybe I understand well. So, for example, for the institutions that they are using hard files, you mean maybe nurses are having their initial assessment, and they have the new nursing care plan, which is written like it's a designed form.
Yeah, exactly. That's what I mean.
What you are. Okay.
Yeah, that's what.
So you are not meaning how to write notes in the progress note of the patient.
Yeah, no, it's kind of different, because you know that we have the form, and also what you write in a progress note every time you come to see the patient. So that's what I mean.
But I think nutritionists also have their assessment form.
But the nutrition, the assessment form doesn't provide concrete and enough information. That's what I mean is, if I come to, let's say, Ashika,
so what do you have in the assessment? If the assessment doesn't give you the concrete information, what do you have in the assessment?
That's what I mean. It needs to be improved.
Oh, okay. Yeah. So let's hear from Adria. I think is the person from Rwanda Nutritionist Society. Who was here? Adrie.
Yes, please. I can.
Joseph.
Yes, I can have an intervention about the Joseph question, but I can apologize to Harriet, because I'm going to talk to Kinyarwanda, because I will need more intervention from other people, so that this question will be effective to everyone.
Yeah. It's okay.
Yes. So, reka dukoreshe uyu mwanya, kuko ikibazo Karemera yabajije kiri kurusho, kandi turakeneye kucyumva neza. Karemera we yavuze ko ikibazo ashobora kuba abona ni uko uburyo aba nutritionists bakora assessment cyangwa nutrition care process yose muri rusange bitari more specific kuri nutrition,
cyane make birakennye.
Aravuga ngo ushobora gusanga ikibazo kiri ahantu habiri. cyane cyane ku buryo baduteguriyemo twandika cyangwa se uburyo twebwe twandikamo information twabonye. Avuga ko mu byo azi abona ko tutandika neza amakuru ajyanye na nutrition. Ubwo wenda nimba nabivuze nabi nawe araza gusubiza, ariko ngewe intervention ashaka gutanga yavugaga ngo ese mwege mukurikije observation bitewe naho mukorera hatandukanye, ari mu bitaro, muri referral hospitals, ari muri district hospitals no muri cabinet za nutrition, mu by'ukuri icyo dukeneye kurenza ibindi ni ikihe? Icya mbere ni knowledge yo gukora nutrition care process. Cya kabiri ni form dukoresha zishobora kuba zitari nziza. Cya gatatu ni standard national dukeneye gushyiraho kugira ngo ibintu bizagende neza. Ubwo buri wese aransubiza icyo abona gikenewe cyane, ariko ku ruhande rwacu na Rwanda Nutritionists Society mbuze ngendeye ku makuru mfite, wenda na president nubwo mbona atari yajoininga yavuga ku ruhande rwe akavugira noza muri rusange. Approach turi gukora ni approach nziza yo kubanza kumenya needs. Training nk'izi iyo tubonyemo ikibazo turacyandika tugaplaninga uko tuzakirisolvinga, ariko turemeranya n'abantu benshi ko hari ibintu byinshi bikeneye gukorwa. Ariko ndasaba ko umuntu wese wumva hari intervention yakora kuri iki kibazo yamanika ikiganza akatubwira ibikenewe byose kugira ngo tubashe gufasha abaturarwanda bose muri rusange.
Remera wasubijwe.
Yeah, sure. Yeah, what is Adrian is saying? Maybe you I don't know if you going to summarize it for Harriet, but what is Adrian is saying? I totally agree with him, and ntekereza yuko bigomba gukorwaho kubera ko hari ibyo tudafite kandi dukeneye mu by'ukuri. So ntekereza ko bazabireba neza bakabinonosora. Murakoze.
Okay, ngiye nkurikije ibyo wabajije n'ibyo Adrien asubije. Ibi bintu ni ibintu tugomba gukora twese dufatanyije tukungurana ubumenyi, kuko ibyo umwe yexpertisinga bitandukanye n'ibyundi. Ariko icyo ntekereza icya mbere ni ubumenyi, kuko ushobora wamaze understandinga the whole nutrition care process, waba na able yo gukora your own assessment form iri rich. Ntekereza ko twese impamvu twananiwe gukora assessment forms nuko nta bumenyi bwimbitse twari dufite kuri nutrition care process. Nicyo ngewe ndimo kubona. So uko rero training zigenda zikorwa, nibaza ko ibi ni intangiriro turimo no kuba designinga form twese duhuriyeho. Nibaza ko atari ibintu byaba bigoye, tukayisharingana twese. Niba abagikoresha hard files biroroshye kuba yaba adapted muri hospital igakoreshwa, ndetse n'abakoresha systems birashoboka ko aba IT bashobora kuzishyiramo aho byashoboka. Kandi bibaye bitanashoboka muri izo new systems, birashoboka ko ushobora gukora na assessment ibyo wabonye biri kurusho ukabyandika muri progress note aho bishoboka. So that is my opinion. Ubwo nutrition society nayo irimo kubireba ibyo turimo kuvugira hano, ndibaza bisobanutse. Nibaza na undi muntu ufite ikibazo ngira ngo.
Esther, to compliment you, when the RNS, for me, after being familiar, studying, gaining knowledge kuri NCP, I have designed the form, and RNS iramutse ko urumva ntago najya gufata form ngo nyishyire hano gutya. It needs to come from somewhere and go somewhere. So RNS, instead of starting from scratch, we can also look mine, bagashyiramo ibindi bitekerezo n'abandi ba expert, then tukareba if we can also have it in our collection as RNS, none asigaye bakazareba uburyo bayadopta n'uburyo bashobora kuyikorera advocacy cyangwa se ku buryo yaba adopted. Yeah, so that's my contribution. So I have one, and also can be looked into and add or remove and it is.
Okay. Yeah, ndumva ni byiza urumva ko abantu bagiye bafite ibitekerezo. So Joseph, ubwo Adrien nawe arimo kubyumva, when they need some people to intervene, azaguhereho rwose. So ndumva twafungira aha. So Harriet,
Hello?
Harriet, are you still here?
Yes, I'm still here.
Okay, sorry, we have changed language a bit, maybe to make it clear to people about the question Joseph was asking. So the Rwanda Nutrition Society is planning to do many things for us, including these trainings, as you said, and we are really humbled and appreciate what you're doing to us currently. So thank you very much. I appreciate everyone's presence for today's evening and presentation. And so Adrien will arrange the next time to resume the presentation, and then everyone will be contacted. So thank you very much. Have a great evening, and may God bless you.
Thank you.
So you're allowed to go.
No, a little bit.
Bagiye we.
I would like to appreciate the presence of everyone in this workshop. May God bless you. On the behalf of the Rwanda Nutritionist Society, thank you for coming. We are going to plan for the second session. Be ready. We'll let you know the time. Thank you so much.